Hello.
Hello guys, sorry.
Hi Riyadh, how are you?
I'm good, how are you?
I'm good.
Rhea, I hope you didn't jump out of bed or jump out of something when I called. Because I feel so bad. It was so much tension coming from Skype. I was like, okay, let me just call. But I don't know if maybe you were napping or something. Sorry.
No.
Good morning. Dr. Riyadh, don't read all the comments about you. We've written an awful lot of shit there.
I didn't read it because I didn't have time to read it.
Yeah. I heard you are the most wanted person right now.
It's funny.
No, you know, yeah, really, I jumped with the Ali telephone. But then,
I knew you did.
but then,
The way you changed your Skype status, I was like, oh man.
but then, you know, I saw also, yeah, there is also my missed call from my brother. But then my phone just died because it was already, you know, it was already not. My phone is already out of charge. Then,
Dr. Riyadh, you need a wife to sort you out.
yeah, this is, you know why, you know why I'm late now after, because I woke up around 15 minutes ago, but I don't know, I didn't find the mic. I said, oh my god, where is the mic? Why I couldn't find it?
Oh god.
Oh, sorry guys. Alright, let's get started.
No problem.
Okay. 1 second. Okay.
Did Valley just say we had need a wife to sort him out?
That's precisely what I said. He'll never be late if he had a wife, because she'd work him for him.
That's a good idea, I think. And I think Riyadh is not married, so we can, you know, we have enough women in our group to start looking. We just have to get the criteria list, you know. She that, and then we can start looking, you know.
Oh, Alex.
We have to talk to Radwan. I think Radwan will give us a, you know, an idea.
All right, guys.
Patience regarding this matter.
All right, let's see. Okay. So we done with vascular, which is basically stroke, and we done with movement disorders yesterday last time. Let's see, we finished. We done with Parkinson, we done with the tremor. I think the last topic was the tremor or the Parkinson, maybe. Yeah. Let's see. All right, guys. Before I will start, let's see how we will arrange the lecture. Okay, so let's start with these four, which is basically multiple sclerosis, Guillain-Barré syndrome, amyotrophic lateral sclerosis. Although, you know, each one, yeah, although these are not either peripheral neuropathy or motor neuron disease. I mean, these are non-categorized, but I mean, these are separate. Not like, you remember when we talked about dementia, you have a lot of differential to go through it, which is basically, it was big diagram. But here, really, I couldn't find how we will make these, because each one is a kind of specific, and it's not so hard. Let's make just simple table about each one: Guillain-Barré syndrome, amyotrophic lateral sclerosis. I think these the three stuff is also important. And what else? Also, I hope I didn't forget. Yeah, just in general, guys, all of these could be young, but usually these two are really young, let's say around 20 to 30. And here in the multiple sclerosis, any female, Guillain-Barré syndrome usually male, I don't know why, and amyotrophic lateral sclerosis usually more than 30 and 40. So let's say the age 40. Now for these two, usually this is just general, very general slide. This is usually immunological. Alright, CSF finding here you will see, for CSF finding is also interesting. This is usually normal, although the protein normal, but part of the protein is high, which is oligoclonal band, which is IgG. But the protein, the CSF normal, guys, it's not high. Usually, again, the protein, the CSF normal, but part of the protein, I mean, different fraction of the protein, you know, you have IgG, IgM, you have a lot of, I mean, different kinds of proteins. So, what is the major constituent of protein N will be, of protein in the CSF of MS will be IgG high. So here a kind of interesting IgG high, that's why oligoclonal band. Again, this is non-specific because could be also present here, could be. But the prototypical features for your Guillain-Barré, guys, you will see protein normal and you will see, the protein high, right? And you will see the cell normal. And you remember what we call this alibonocyto dissociations, means there is even if it is protein high, the cell will be normal. And because these are immunological, that's why you can assume a treatment like steroid here. Alright? And on Guillain-Barré, you can go with the plasmapheresis. Right, and the second one, what is it? IV immunoglobulin. While ALS is not immunological mediated, ALS is usually degenerative disease. So because really there is no treatment for ALS, I can say. However, they discovered a drug which is not recently, maybe 10 years, which is riluzole. Not sure about the spelling, but this riluzole is a glutamate antagonist drug, and this drug basically just increase survival. So it is have survival benefit. It's not curable, sure. Yeah, one more thing, I just forget it here. I just go to. So guys, I think the keyword, yeah, there is keyword for each one of them. Just one word to know what he's talking about. So yeah, guys, give me keyword for multiple sclerosis, whether in your test or even in the real life. Keyword for multiple sclerosis.
Blindness. Having function of plaque.
Multiple symptoms and sparing.
Same.
Neuropathy.
He's almost right. So basically, you got recurrent, relapsing. So the symptoms, guys, recurrent. She came with blindness today, and you give her steroid. After 5 days, she's fine. Everything is fine. And she's run out recurrent relapse, or you can say not recurrent. Recurrent is almost the same as relapse. So you can say relapse and remission. Alright? And I will give you the scenario. How about the key point for Guillain-Barré syndrome? It's paralysis. And this paralysis is, descending or ascending paralysis, right? Key point for ALS is motor. So here only motor affected, and I think most of you know the ALS, which is basically you will get upper motor neuron disease and lower motor neuron disease. So you'll get lower and you'll get upper. Just a few seconds, we'll talk about this in more details. But I think regarding the treatment, this point is interesting because it's immunological, so don't put steroid or anything in the motor. And regarding CSF finding, this is also kind of interesting. Why CSF finding in Guillain-Barré you will see high glucose, you will see high protein and normal cells? Because it's not infection, and the protein just indicate the inflammatory markers. Why the protein is normal but only IgG of the protein, I'm not sure really why this one is. But also this indicate, because it's IgG, that indicate inflammatory, which is a kind of neurological markers. Now, some of the tricks for each one of them, which are really so high yield. So multiple sclerosis, guys. First, we just talk about relapse and recurrence. So I don't think I need to go through the clinical features, right? You know, optic neuritis, which is blindness, any features, guys, maybe weakness. So what we like to do, either acute or relapse remitting. There is two disease, either so 2 or 3 forms. The first form is acute form, like blindness, which is optic neuritis. The second form is relapse remitting, means she has attack now after 1 year free. So I think this is easy. And the third one, let's make the third one here, which is secondary progressive. Means usually start as acute and then go and then worsening from the name. Secondary progressive means this is worsening. You can say this one relapse and remitting, you have free period, and this is just acute. Now, what is that? Headache, facial pain. This pain is sharp, lasted within 10 seconds, recurrent throughout the day, very severe. What is that, guys? What I'm talking about? What diagnosis here?
Tension headache.
No, it's facial pain, and facial pain sharp, 10 seconds, and every 10 seconds, last 10 seconds.
Trigeminal.
Right.
Trigeminal neuralgia.
So this is trigeminal neuralgia. Why I put multiple sclerosis with trigeminal neuralgia? What I want to say. What is the relation here?
Monopathy.
It's right, but I mean, so could multiple sclerosis be presented as trigeminal neuralgia? Yes. How?
Not.
I mean, yes, but what is the difference from others? How you know? How you know in your test? This is a clue for multiple sclerosis, which is basically bilateral. So bilateral trigeminal neuralgia, guys, the only time usual trigeminal neuralgia regularly just unilateral facial pain, right sided, sharp, whatever. Bilateral trigeminal neuralgia, this could be indicate what? Multiple sclerosis. All right. So this is the first thing. Acute treatment. Give me the drug of choice for acute treatment, guys. Stop.
Carbamazepine.
Oh no. I mean, sorry. Acute treatment for multiple sclerosis. Acute. How you
Interferon?
No.
Steroid.
Oh, steroid. And the steroid is high dose steroid. Those patients, they take 1 gram steroid daily. So high, not just steroid, high dose steroid. Now, relapse and remitting, there are drugs that decrease the second, relapse and remitting maybe, or basically acutely to secondary progression, or secondary progression just increase the progression. So there are drugs that basically working here or working there that decrease the progression. So you can say the drugs, the function of the drug prevent relapse or decrease progression or decrease disability. Give me the drugs, guys.
Interferon.
Beta interferon, you are right. Someone said glatiramer acetate, he's also right. Glatiramer, whatever, acetate. What else? How about IV immunoglobulin? It's usually a question. I mean, not sure. Although, you remember, guys, I said in immunology. I say it because it's immunology, so you can't trace it by IV immunoglobulin. But it's a question. I mean, don't choose it. It's not 100% approved like Guillain-Barré syndrome. Now, how you'll stop? So you prevent relapse, prevent compression, then you have, so what? You have interferon, you have glatiramer third, you have third category, which is immunosuppressant agent. Give me one of immunosuppressant drugs that used in MS.
Azathioprine.
Azathioprine. Maybe. What else? Maybe you are right. Maybe I'm just not aware of. But there is a drug which is usually, I mean, we need to know the typical one, which is
cyclosporine.
Right, cyclosporine. So usually immunosuppressant, you can go with cyclosporine. Now, is there any rule of plasmapheresis? Also positive, negative plasmapheresis. So there is rule. There is rule for plasmapheresis. But the least rule, which is a kind of controversy, not controversy basically, I don't think they use it, is IV immunoglobulin. So don't choose IV immunoglobulin as the answers. Usually the answer will be either a steroid for acute treatment, which is so high yield, because acute treatment just represent top emergency. So usually the answer will be just either steroid, or maybe for the chronic, the drug of choice, usually they like either interferonic, latimer acetate. I don't think they will ask you about immunosuppressant drugs. All right, any question?
So I also found out with the secondary progress, does it have a treatment?
Yeah, in order to prevent the progression.
Okay.
Yeah, sure, you will give a treatment in order, because I said these drugs working either prevent relapse, that's mean here, or prevent progression, that's mean there, and the secondary progression. So these are the chronic drugs, or long-term treatment. Yeah, sure, there is treatment. Okay, guys. Okay, what else I need to do?
Baclofen for...
Oh, baclofen for spasticity?
Yes.
Yeah, although it's non-specific, but you are right. As a general measure, you'll use baclofen if the patient have maybe respiratory problems. Sometimes we will use oxygen. You need to give some anticholinergic drugs for bladder control. These are general measures, which I don't think they will ask about these. I mean, because these are just general medicine. They will ask a drug of choice, which is acute or treatment. And I think this one is very high yield, guys, and maybe you know that, which is basically if I will ask the patient to look to the left, or maybe I will ask to look to the right. So look what happened if I will ask him to look to the right and I will ask him to look to the left. When I will ask to look to the left, basically the right eye just remains in neutral. So this is not working. While the left, there is no problem. There is abduction. But with abduction, what I will see, guys? So there is abduction, okay. But with abduction, what I will see? Give me sign.
Nystagmus.
Very good. So here, nystagmus. And the right, in just the opposite. So in the right, when I will ask him to look to the right, basically the right eye is... the right eye will see here the nystagmus, and the left one will see stationary. And most of you know what is the problems here? Quickly.
Internuclear ophthalmoplegia.
Right.
Ophthalmoplegia.
And what is the problem in which drug? In which tract?
Medial longitudinal fasciculus. MLS.
Right. It's the problem with medial longitudinal fasciculus, which is MLS. And what is the problem here in the medial longitudinal fasciculus? Just demyelination problem, right? Because that's it. And how about the convergence? Is the convergence intact or not?
I guess intact.
Yeah, guys, the convergence intact. That's why I'll make it like this. So the convergence is okay. Now, is there any nystagmus during convergence? No. So convergence is okay, and there is no nystagmus. It's anatomical point here. But it's, I think, too detailed, so anatomy you don't need to know. But the convergence is intact, no problem. Alright, guys. So this is also about MS. Now we talked about CSF finding, which is normal pressure, normal cells, normal protein. Everything is normal, but you know IgG, which is oligoclonal band, high. So you have to know this is this one. Although I think the oligoclonal bands is high. All right, so I think that's it about the MS.
I'm sorry, Oyab. Isn't the adduction which is affected, not the abduction?
Yeah, not the abduction. Okay, the abduction is also affected, right? Look at the right eye. In case when we are looking to the left. So the abduction.
Yeah, the right eye cannot move, so abduction
Right.
is also.
So it's also
Oh,
affected.
so you mean the right eye, which is the affected one, it cannot be moved to the medially.
Left. Right. So that's.
And the abduction is normal for the left eye. Okay.
Right. Abduction is normal for the left eye, and the opposite is the opposite. I mean, when I asked to right.
Oh, yeah, makes sense.
So the right eye here, it's okay. There is abduction, but with nystagmus.
Okay.
And the left eye is stationary. So the problem with the left eye.
Thank you.
Yes, the problem here in this fasciculus, which basically linked oculomotor and abducent nerve. So there is a problem with both, but I don't think you need to know the details here because it's really difficult anatomical part. Okay, so I think these are the things about the multiple sclerosis. Okay, what else? Second one, what is the most common organism that blamed for Guillain-Barré syndrome, guys? I think this is also easy question. Why? What is the theory? Okay, right, Campylobacter, which is, so basically we'll see history of the area. This is not a big deal in Guillain-Barré syndrome, right? And it's paralysis, so it's also motor. Now, is there any sensory problems with Guillain-Barré syndrome? Yeah, sure, because it's peripheral nerve, so sure there is sensory problem. Is there any autonomic problems? Autonomic dysfunction?
Yes.
Yeah, there is autonomic dysfunction. 50% of them, they have autonomic dysfunctions, which is basically a third or fourth cause of autonomic dysfunction, guys. We didn't talk about autonomic, remember, when we made this differential. So first you have to know it's acute presentation. I mean, needs around 3 weeks, and there is bacteria, usually the cause, or maybe infectious, as a theory, is the cause. And the second, it's usually weakness. So basically, I'm talking about ascending paralysis. And what else? A plus, so here is the motor. With the motor, sensory is affected. Autonomic nervous system is affected. I think 50% of them have autonomic nervous system problems, plus cranial nerves. Cranial nerves could be also affected. What is the most common cranial nerve affected in case of Guillain-Barré syndrome, guys? Which cranial nerve? Patient will come with facial problems, maybe numbness, maybe, you know, I don't want to say more. So what?
Facial pulse.
So facial pulse. Right, no, facial. Facial usually it's the most common cranial nerve affected, so facial palsy is the most. So cranial nerve, not cranial normal, cranial nerve problems like facial palsy. And if you remember, because I'm talking autonomic nervous system, last time we made differential diagnosis of autonomic nervous system dysfunctions regarding diseases. DM is still, guys, I think #1. Parkinson disease is maybe important. I'm not sure this #1 or 2. Guillain-Barré syndrome is also important. And you remember in Parkinson we talked about shy dragger, which is basically, I think, like this, or shy whatever. And this DM, Parkinson, Guillain-Barré, these are the 3 really big times presented as autonomic problems, which is basically problem with postural hypotension, or, you know, gastroparesis or urine problems. Plus, there is also some disease which is generalized. Everything is just crazy. I think there is disease which is genetic. All right, so don't forget these, because last time we didn't talk about Guillain-Barré, I believe. So okay, so these are just ascending paralysis. So So that's really, I mean, there is no big talk about Guillain-Barré. I'm trying also to find if I missed something, but how you diagnose this, by the way, here? In vitro diagnostic study. What I mean by in vitro diagnostic study, basically nerve conduction study. All right, so it's nerve conduction study. Why nerve conduction? Because this is peripheral nerve. So dealing with nerve, that's why nerve conduction study will be the answer. Yeah, by the way, guys, sorry. Differential diagnosis of investigations. So here nerve conduction study, MRI will be the answer for multiple sclerosis. And what you will see in MRI of multiple sclerosis patient, what you will see, guys?
Class. You see the class.
Where is it? Where? Right. So periventricular calcification, guys, and you need 10. By the way, you need to find 10. Although it's not important for you, but you need to find 10 in order to say this multiple sclerosis. So it's periventricular calcification. Okay, so don't forget the MRI here, nerve conduction study there in Guillain-Barré syndrome, and in Guillain-Barré syndrome. Treatment, I will just say it. Treatment is interesting. Why? Because if you don't treat them, they are fine because it's really self-limited. 90% of them self-limited, but we still treat because we're afraid about one thing. So basically, the treatment divided into two things: either treat, which is basically by IV immunoglobulin or plasmapheresis. What is the second line that you are afraid of? Second thing that you need to monitor, which is also easy.
The upper respiratory tract muscle, the diaphragm.
Right. So what you will do to monitor the diaphragm and upper respiratory muscle?
Function test.
Right. And
Not intubate.
PFT.
no, before. Oh wait. Before intubation, it's just monitoring.
The pulmonary function test?
Right, pulmonary function test, and basically what you will see only one thing that you need in pulmonary function test, which is you measure vital capacity for this patient.
His vital capacity.
Right. So you measure the vital capacity every 2 or 3 days. I remember every other day you measure vital capacity to see if there is any decrease in vital capacity. That means sooner or later patient will need, or at least you will consider. You'll consider intubation. Alright, you'll consider intubations. Question?
I want to ask for the Guillain-Barré syndrome. Initial test, can we check for the bacteria in the blood or whatever?
Oh no, I don't think so.
Because they always have issue that this can be bacteria, whatever.
I know. You mean the initial test? I'm not sure what is the initial test. Maybe CSF will be initial. I'm not sure about the initial test for Guillain-Barré because it's a kind of clinical.
Okay.
So really, it's a clinical diagnosis. But I really don't know. Nerve conduction study. They can consider nerve conduction study as an initial test or as a confirmatory because nerve conduction study is non-specific. But that's really I don't know whether it's initial. I don't think initial test and confirmatory test here will be a question. But honestly, I don't know. But you will not go with bacteria stuff. Why? Because it's theory. It is not 100%. Guys, it's immunological mediated and just environmental problem, maybe bacteria. It's not 100% linked to bacteria, but in theory, they said usually linked to the infections, but could be also occur in HIV. Could be also occur. I remember Hodgkin's disease, lupus. Sometimes just whatever, nothing. No patient does not have anything. So that's why I don't think go to examine bacteria will be the answer. Now, so we done with 2, which is Guillain-Barré and motor. The next one, I forget it. Guillain-Barré syndrome. Now, motor neuron disease is also easy because most of you know the presentation. It's very easy. Most of you know lower motor neuron disease and upper motor neuron disease. And lower motor neuron disease, where usually it's upper limb, so you will see hand wasting or wasted hands. So this is the first presentation. And upper motor neuron disease, that means Papinski sign positive. So usually upper motor go to the lower limb and lower motor go to the upper limb. And really, I don't think there is big deals about the diagnosis, which is basic diagnostic questions. And then the treatment, I just talk about Ralph. So I don't think there is too much talk about motor neuron disease. Okay, guys, any question?
Sir, I guess Fatima wants the link for the screen.
She's not here. Oh, okay. Sorry, guys, 1 second.